Hello and welcome to this presentation. I would like to thank Johan Hartmann and Balazs Ach for their roles in inviting me to speak before you today. My lecture is entitled TILs, Tumor Infiltrating Lymphocytes in Cancer, from H&E to DSP, Digital Spatial Profiling. And what I hope to convey to you today is starting from the H&E and going into some of the most sophisticated pathology techniques. This lecture will be targeted at both practicing and research pathologists, so thank you for the opportunity to provide this. In America, whenever we give a lecture, we need to show our disclosures. So these are my disclosures, and I would note that that I do spend a fair bit of time speaking with commercial ventures in the US, and that some of the work that I'm going to be sharing with you is supported by commercial as opposed to public funds. The session today will go as follows. I would like to start with talking about TILs, tumor infiltrating lymphocytes, and give you a very brief history. Then we'll talk about TILs in breast cancer, predominantly automated TILs, and then TILs in melanoma, again, our automated methods for assessing TILs. And then we'll bridge from automated analysis of the H&E to molecular analysis in melanoma, and then ultimately to digital spatial profiling, which is really not related to TILs, but sort of the next, I think, an example of high-plex technology, which can be applicable to many aspects of pathology, including tumor infiltrating lymphocytes and many other aspects of assessment of the molecular content of the tissue that we receive as pathologists. So this takes us back quite a while ago. 1920 is, I believe, the first paper that described tumor infiltrating lymphocytes, where Dr. Sustrunk and McCarty said that patients with glandular and local lymphocytic infiltration, this is in breast cancer, lived 146% longer than patients without glandular involvement, or with glandular involvement but without lymphocytic infiltration. And so this kind of gives a general hint as to the mechanisms. This slide shows sort of where we are now with TILs. And this guy, Roberto Salgado, is one of the real leaders in this field and has gotten us all together as part of this working group. And as part of this working group, we've done some studies on pathologist assessment of TILs, and also you can do your own. Oops, sorry about that. You can do your own assessment of TILs. Let's see if I can grab a laser pointer here. And you can learn how to assess TILs according to the internationally unified method, pathologist-based TILs. And when we did that, initially back in 2014, actually back in 2012, we had some not such great concordance, and then we did it again. And this time we spent a lot of time thinking about how we should read TILs as pathologists. And we had two kinds of TILs. We had stromal TILs, which are sort of in between the epithelial islands or tumor islands, and then intertumoral TILs, which are lymphocytes that we morphologically define as within the tumor bulk itself. And it's interesting to think about the two different possibilities as you define them. And then a key thing I'm not sure whose idea this was, but that Roberto provided for us was these guidelines, so that our TIL image, digital image, was between these guidelines. So we could say, oh, that one looks like a 60%, or that one looks like a 20%. And that helped us to increase our accuracy. And a result of that, we got our inter-class correlation coefficients to be quite high, certainly above 0.7, and in some cases even above 0.9 agreement between pathologists. So pretty good. This is summarized here in data from the TILs working group, the international working group. And you can generally see that even within a stage, 1 to 3 positive nodes, greater than 3 positive nodes, the more stromal TILs you have, the better you do. And one of the conclusions of the working group was actually, it was the stromal TILs that we are most accurate in reading. And even though intertumoral TILs may be important, as I'll share for you hopefully in the future or maybe later on, this really is a variable marker or an important marker. And this was summarized. I think Shireen Loy is the first author of this work in JCO a couple of years ago, which is, I think, the most comprehensive look at TILs in all of these clinical trials that are done here. And you can see that almost without exception, the patients that had high TILs are doing better than the patients that don't have high TILs. So a prognostic marker, not necessarily a predictive marker, but perhaps in the future a predictive marker as well. Here showing the prognostic value across many clinical trials. But the clinical guidelines haven't moved. In St. Gallen in 2019, they still recommended TILs. The data around TILs is inadequate to recommend TILs as a test to guide neoadjuvant therapy. So some places do it. At Yale here, we do not read TILs routinely on every case. And I think that's the case in the majority of US institutions, that TILs are interesting, but not quite standard of care yet. And so how might they become standard of care? This is just sort of a quick peek into where we're going and what's happening with TILs. And that is the prognostic value of TILs in triple negatives in the adjuvant setting, or do not receive, potentially in the neoadjuvant setting. And you can see in this article that we see that TILs, high TILs greater than 30%. So we defined a cut point, and they certainly do better than patients with low TILs. And I think this is a precursor to looking at TILs in triple negative breast cancers as a way to potentially de-escalate therapy in older patients or patients that have high TILs and really don't have such a good survival curve that they're unlikely to need TILs. But maybe the problem, and what has been complained as a problem, is that, well, it's different at every site and every pathologist reads TILs differently. And is there a way to standardize it? So now I'd like to spend some time talking about automation of TILs. And one of the first papers about automation of TILs came from the Joe Saltz lab here at Stony Brook in New York. And he had a number of people working with them. And they made a computational way of looking at TILs, where they looked at all these slides in 13 different cancer types, and then put them through this sort of deep learning machine, and ultimately came up with ways of classifying TILs and measuring TILs that were kind of what we expected. You can see in the breast cancer group down here, the basals and HER2 are higher, but they could measure TILs in every tumor type looked at. And in fact, they had good correlation with pathologists. So if the pathologist called it low TILs, they also called it low TIL, same thing in median and high. And so this is kind of suggesting that deep learning and algorithms could be used to read TILs that might get rid of some of the variation that's seen from pathologist to pathologist or even site to site. In spite of Roberto Salgado's best efforts with the International Working Group, this would potentially lead to greater standardization. So what are the methods for automated TIL or machine reading of TILs? And one is bespoke coding, and that's what the Saltz group did in their report in Cell and continues to do, where they use their own systems and do absolute coding, although they may use some publicly sourced data. The entire package is not in a manner that I as a pathologist can pick up and use, or that can easily be incorporated into clinical work in the US or anywhere around the world for that matter. There are commercial software like Halo and Visiopharm and others that can do this. And that might be how this rolls out, is that some commercial company can often sponsor these, and we could see in the future somebody commercially sponsoring or sponsoring a way to do machine TILs. Or we could use open source software, and then we can sponsor ourselves. And this is what I've been trying to do, introduced to my lab by your resident, Balazs Ach. And the rest of the talk, I'm going to talk a lot about QPath. So QPath is one of the pieces of software we use heavily in our lab to analyze tissue. And it's an open source software for quantitative pathology, originally developed by Peter Bankhead at Queen's University as part of his PhD thesis. There's quite a few papers in the literature now. And according to Peter, it's been downloaded thousands of times, and there's thousands of users around the world. And if you're a coder, you can write your own algorithms and extensions and scripts. And even if you're not a coder, if you're some kind of, if you're a pathologist like we are, then you can still use it. And in fact, it was Balazs in the lab before he started his residency that really piloted the use of CoPath and this workflow. That is estimating stain vectors, segmentation of the cells, classification and machine. And this is the machine learning part that picks out the TILs, and then analysis on multiple cohorts. And so I want to take a minute to sort of take you through this to see how basically easy or not so easy it is. And this is kind of how it looks. Is the first thing that people struggled with back many years ago when we tried to do this was to try to get the H&Es normalized. And so what you do is you normalize the stain vector, and I'm going to show you that again. So basically you take the the cursor and you move it so that you're normalizing the H&E for all H&Es, so that the H&E stain in your lab doesn't affect how the algorithm works. And so you take an image that looks like this, and then you normalize it, and that changes, and it actually took some of the blue out by normalizing the stains. So here's the complete pathway of how this works, or how we did it in our first, and I'm going to describe, even though we did this second with breast cancer and first with melanoma, I'm going to describe breast cancer first. And so you estimate the stain, you train and build the classifier, then once, and we're only classifying 4 cell types: tumor cells, TILs, fibroblasts, and other cells. And then once we have those 4 cells classified, that's a trained classifier or an algorithm. And then we do math on them and then test them on various validation sets with the ultimate hope of taking them to the clinic. So here's an example of the kind of math that we do. And that is, if we have 4 cell types that are pretty accurately defined every time we run a specific classifier, in this case, our classifier is called CNN11, we can have different calculations where we have actual math, like, and actually I'm going to show you this. It's easy, perhaps easier to understand as a picture since we're pathologists. And so you can take TILs divided by TILs normalized by lymphocytes. And so that, I'm not sure why this is advancing automatically on me, but it might have something to do with Zoom. But what this was a kind of, there's lots of different mathematical formulas you can apply, and the only automation was actually picking these 4 cell types. And so this is what I hope we can use the automated part for, and then do things that pathologists can't do. That is, we could technically count every fibroblast and every other cell and put that in the denominator and count every lymphocyte, but that would be impractical. Instead, let's have the machine do that for us, and then look at different algorithms for defining each of the different potential variables that we call these the variables, and the algorithm is we called CNN11 for convoluted neural net 11, which would just meant it was the 11th build of that algorithm. And we can make that publicly available, and in fact have made that publicly available. And in fact, as Balazs will point out to you, his algorithm that we made publicly available in melanoma has now been used by other groups and shown to be validated without either of us participating in their study. So this is how it works, just in breast cancer again, the tumor cells, the TILs, stroma cells or fibroblasts and other cells. And here's how it assigns. It does pretty well. You can see the fibroblasts are here, and there's some undefinable cells here and there, but a lot of the TILs are appropriately identified, and a lot of the tumor cells are largely appropriately identified. Is this 100% right? Probably not. But if it's 95% right, because we're going to do math on it, it'll probably be good enough. Here's another example. And so you can take a look at the H&E first, and you can see all the TILs here, and a lot of stroma in this particular breast cancer case. And then when you assign the locations, you can see the stroma is appropriately picked out as fibroblasts and some other cells. But the lymphocytes are all pretty much picked out as lymphocytes, and the tumor cells are picked out of tumor cells. So does that mean the pathologists are done? Not really. Here's a case where it fails. So this is a case of a poorly differentiated breast cancer. And you can see in this case, even though we circled the regions of interest and didn't have it look at the whole slide, when it assigns the tumor cells, it actually misassigns a lot of tumor cells to the lymphocyte category. So pathologists have to check up on these things and make sure that we don't need to eliminate the case as we did in this calculation. And this is just considered an AI failure. And artificial intelligence sometimes fails, and that's when we need real intelligence and real pathologists to sort of censor those cases. This happens in our experience less than 1 in 100 times. So it's not that prevalent and still can be used as a clinical test, but an important part of the clinical test has to be pathologist review for AI failure. And so here's how we did when we looked at the validation or the training sets. The training sets for various variables, we had eTIL percent, eTIL total, ES-TIL, which is stromal TILs. The one that's most similar to pathologist read TILs is called EAS-TILs, which is very similar to when we had our Yale pathologists read it. And you can see that, and that's based on the area covered by the TIL, by the lymphocytes themselves, divided by the total area of the stroma. And you can see the similarity here. In this case, as expected, pretty much the training set is pretty nice. It pretty much validates. in a set that we got from Balazs and Johan Hartmann in Sweden, this is the name of the cohort of triple negative patients, and there were 216, and this was our validation set. And surprisingly, it didn't do so well. Actually, manual TILs did okay. They were statistically significant, but the rest of them, even the machine learning manual TILs, didn't do as well. And so we asked ourselves why this might be the case. And in fact, we found maybe it's got to do with the cutoff, but what it really has to do with is stage. This is a really interesting observation that isn't published yet, but is about to be published, that TILs are highly dependent on stage. And so TILs, when we looked at our algorithms, the TIL algorithms worked really well in the training sets and validation sets from Yale, but not so well in the validation set from Karolinska. And that's probably because the stage, look at how many stage 3s and 4s there are in the Karolinska cohort compared to how many stage 3s and 4s there are in the Yale cohorts. And I think that as we go forward in the future, we'll have to have, and we're doing this in melanoma, as I'll show you shortly as well, we'll have to have stage-specific algorithms and stage-specific variables, because even though as pathologists we can read across all the stages, it's likely that stage is actually highly influential on TIL tumor lymphocyte infiltration. So here's the final validation, and the people working on this, Yalai in my lab, and then Balazs at Karolinska. And you can see that actually it validated quite nicely on TCGA. I'm sure you're familiar with that, and had very high hazard ratios or very low hazard ratios for prognosis. And you can imagine something like this, eTIL percent or eTILs were our best performers on the validation set. The pathologist equivalent didn't perform so well, but maybe that's not a true pathologist equivalent. But so what we wanted to do is compare all these, and ultimately we could envision this kind of follow-up being tempting for patients with triple negative breast cancer to not get follow-up chemotherapy. And that's what's next. Well, I don't have that data yet, that trial hasn't started, but that's what we envision, is trying to use this in the neoadjuvant setting. So here what we did is compare each of the variables to see which one was the best. And if you look at the hazard ratios, which is really, you're not supposed to compare, if you ask your biostatisticians, they tell you not to compare p-values, but to compare hazard ratios. And you can see our worst one was actually the one that mimics pathologists, and it was 0.57. And our best one was all the stromal cells combined as the normalization factor, although the one that we use most commonly, eTIL percent, which is just TILs divided by tumor cells plus TILs, is actually pretty good, maybe not that much different than 0.59. And certainly the 95% confidence interval suggests none of these are significantly better or worse than others. But interestingly, all of them are significant in multivariate analysis in terms of in the validation set, which was a combined set that combined the low stage patients from Yale and Karolinska cohorts. And this has actually been accepted for publication. Balazs is a communicating author, and I think we'll see it in about 2 or 3 weeks. And then you can take a more careful look at this data. But for the sake of this talk, let's move on and talk about TILs and melanoma. Since my lab doesn't just work on breast cancer, we work on biomarkers in breast cancer, melanoma, head and neck cancer, and to a lesser extent, lung cancer. And so in melanoma, we have a specific problem that I think TILs may be able to address, and that is this. So this is the adjuvant setting for melanoma, for pembrolizumab in the adjuvant setting in stage 3 melanomas. And so what you can see is that 50% got placebo, and they're still alive at 2 years. And actually, they now have the 3-year follow-up that I didn't quite get to update this yet. But it pretty much levels out. I think goes down about 43%. So that means 50% don't need pembrolizumab because they're cured by surgery alone. And 30% of the patients that get pembrolizumab recur anyway, so they don't benefit. So that means in the adjuvant setting, only 1 in 5 patients benefits. Wouldn't it be cool if we had a way to stratify that 1, or at least 2 out of those 10, to get, so that we could exclude some patients that we know are not going to benefit, and some patients that we know are cured by surgery, so that they don't have to receive the risks of pembrolizumab. Not that pembrolizumab is that toxic a drug, but in fact, in this trial, 1 in 100 patients dies from drug, which is not so good in the adjuvant setting. Certainly in the metastatic setting, we want to give everybody drug, but should we give everybody drug in the metastatic setting? And nivolumab was also looked at in the adjuvant setting, and it had even fewer percent, 11% or 6% benefit. And so I think this is a place that we need TILs. So how are we going to do this? And this is actually now I'm going to share with you all published work on TILs and melanoma. And again, we do the same thing where we train, and we made a training algorithm. The royal we, it really means Balazs made an algorithm that he calls NN192 that appropriately assigns the cells as tumor, TIL, stromal, or other cells. And then we do the math. That is, we use mathematical computations to make variables that we can then use for melanoma. And in melanoma, we started by just using eTIL %. And what we found in the training set is it separated the populations quite nicely, even though the pathologists on that same training set who called absent brisk or non-brisk had less success in separating that cohort. Then we took it to ask the question, well, aren't we doing something we could just do with IHC? And the answer is kind of no. If we looked at CD8 or CD20, they're related, but they're not, it's not the same variable. It might be an additive thing. Here's CD4 as well. They're all related. All these lymphocyte molecular markers are related, but they're not equal to TIL. And so then the next thing we did is try a couple validation sets. And here's a validation set on a Yale cohort, which was a TMA, and another validation set, YTMA 76, which was all stage 2 and stage 3 patients. And again, both validate with hazard ratios in the 0.35 range. So optimistic, but this was all done on TMAs. So Balazs thought we need to do this really on whole sections as if we were really in the clinic, and then first circle the region. So even before he started his residency, Balazs was somewhat of a pathologist, circling the appropriate part of the tumor for analysis, so we're not wasting time analyzing regions that are not tumor. And on these annotated whole sections, our data looked like this, which is really quite impressive. The difference between sort of a 10 to 15% recurrence rate versus a almost 90% recurrence rate, and a hazard ratio below 0.1. And so the next thing with great excitement, we moved from this whole slide to another whole slide cohort with the same classifier, but whole slides from another institution. And as you might expect, everything regresses toward the mean, and so did this. Our hazard ratios are still pretty strong at 0.33 or 0.34, but using the Balazs classifier on the Columbia cohort from Yvonne Sanger's group at Columbia, a smaller group, so perhaps less statistically powered, and a cutoff around 20% or around our normal cutoff, still showed us pretty, excuse me, fairly compelling differentiation. So the next step is to really try this in other cohorts. Actually, the next step was to publish this, and Balazs led this work, was published a couple of years ago now. So the next steps were to make a low-cost prognostic marker for stage 2 or stage 3 melanomas for use in the adjuvant immunotherapy setting. And to do that, we needed to first test, we needed to find patients. So this is the variable we used, eTIL %, and then determine the best praise, and then to validate on non-Yale cohorts. So the next cohort we went to was Ayman Osman's cohort from NYU. And we asked her for a low stage cohort, but she didn't quite understand that part of the request, and instead gave us 78 patients in stage 4, and the rest of the patients were low stage. So how do we do in high stage? And this is interesting, and we see the same thing in breast cancer. High stage is a different disease. When we use our standardized cut point of 16.6 eTIL %, we don't see any separation in the high stage patients. It TIL may still be important, but it requires a different cut point. And in fact, at a much lower cut point, that is detecting a lower level of TILs in higher stage may still find prognostic value, but you don't see the performance of high stage patients because generally they do worse. And in fact, it's hard to even do this now because so many high stage patients are getting immunotherapy. But again, as we showed in breast cancer, the NYU cohort was essentially all stage 4 and 3s compared to the Yale cohorts that were all predominantly 1 and 2 with a little bit of stage 3 and barely a stage 4. And so I think this shows the importance of stage. And in fact, then we started validating on lots of other cohorts. So here's a TCGA cohort. It does really nicely. These are all stage 1 and stage 2 patients, and it's 137 patients, so more than almost twice the number of the Columbia cohort, the same cut point, and now a hazard ratio back similar to the Yale hazard ratio of 0.93. This was, again, whole slide study. And you can imagine these maybe being cases that should forego immunotherapy in the adjuvant setting anyway, because they do pretty well. Whereas these cases, if you're in this group, in the adjuvant setting, you need immunotherapy. Here's the other cohorts that we've looked at, and that includes a cohort from Sydney, Australia, a cohort from Tübingen in Germany, and the Yale and the combined Yale cohorts that are in a study that's now ongoing. And the ongoing study shows you a little bit of the distribution and the type of, in terms of ulceration and stage, et cetera. And you can see that these are now in these combined cohorts are mostly low stage patients. We've eliminated the high stage patients. And when we look at each of these cohorts, the Sydney cohort is not quite statistically powered, so it's not statistically significant. But the other cohorts look good. And then if we combine all three so that we have 477 patients, we have a fairly promising looking validation of the eTIL percent with Balage's cut point of 16.6 eTIL percent. The next step was to show this as a forest plot, and you can see what the hazard ratios are, because we can compare the hazard ratios. And the hazard ratios in the cases with more low stage were lower. So probably stage 1s aren't going to get immunotherapy anytime soon, but trials are already beginning in immunotherapy adjuvant setting with stage 2s. And stage 3s, it's already the standard of care because of the 2 papers that I showed you in the beginning. And in fact, many stage 3s, most of our stage 3s here at Yale are in fact getting adjuvant immunotherapy, either Pembro or Nivo, depending on the clinician. And so this would potentially be, shows that this validates, and we're hopeful that this could potentially be used in the future in a prospective trial to try to validate melanoma patients for either treatment or non-treatment in the adjuvant setting with immunotherapy. In high stage, we looked again at, we combined the combined cohorts and looked at all the high stage patients and proved once again that if we're going to do high stage work, we're going to have a separate cutoff. And it's not clear what the clinical utility would be for high stage assessment of TILs. Since high stage melanomas, pretty much we already have a pathway for them. Perhaps we would be able to someday predict responders to immunotherapy, but that would still, I can't foresee a situation where a high stage patient would not get immunotherapy. They would have to progress on immunotherapy first, and that's a whole different kettle of fish. So this is comparison. I'll skip this slide to go for the summary. eTILs percent can be easily determined by open source software. And in fact, other people, and I don't have that reference in here yet, but other people have downloaded our eTIL algorithm, NN192, downloaded QPath, and actually run and published papers in low stage melanoma showing that hazard ratios between 0.1 and 0.4. But it's stage specific. Don't try it on stage 3 and 4. It won't work. Other computational variables, including mimicking a pathologist, are approximately similar, but are still in testing. And in the future, we hope to begin some sort of adjuvant trial and prospectively here at Yale, or perhaps with one of the US cooperative groups. But this raises the question, well, what are those TILs? What are we actually looking at? And in fact, one way to think about that would be to look at the actual TILs with a molecular tool. And so we're taking what Fazin Ang in my lab, a new postdoc in the lab, has taken our molecular quantitative fluorescence images like this, and then we take different TIL variables. In fact, she's looked at 6 or 8 different molecular TIL variables and defined each of them, and then using the Vector Polaris and Inform software, counted up how many of each TIL there is, and then compared them to the same H&E images. So these were actually the same cohorts that we analyzed by eTIL percent were also analyzed by molecular parameters so that we could compare the two. And in fact, we did the same thing we did before. That is, we reran all of the algorithm on this, and this is actually one that Balazs had as one of his Yale training sets, and then we did the molecular testing. And what was shown by Fazin is that, and I'm not sure I like this plot yet, but the H&E TILs and then the regression or the correlation coefficient with everything else. So the correlation with CD45 is the highest, no surprise there, between H&E TILs and H&E, because this is essentially catching all the white cells. But what about CD20? Well, there's a correlation that's pretty good. It's statistically significant. But in fact, other things don't correlate so well. So it's not neutrophils, they don't correlate very well, but CD56, not so good, 0.2, but CD3, T cells really high. So it seems to be perhaps driven by T cells and maybe to some extent B cells. If you look across, the B cells is 0.4, CD14 is 0.59. So this is giving us a little picture. This is a little bit preliminary, but it's kind of what we'd expect. That is, that the molecular parameters that we see that correlate with H&E TILs are really CD3 and CD8 and CD20 that have the best correlations with H&E TILs. And so another thing that we've done on a treated cohort, now this is now patients treated with anti-PD-1 therapy, and I won't go into this a lot. This is already published a couple years ago by Pak Fei, a graduate student at the lab at the time, now working at Verily. And you can see that in anti-PD-1 treated patients, CD8 separates the population very nicely, whereas CD4 not so much, or CD20 much. Whereas in the control patients, this is a historical cohort, CD8 doesn't work as well. In fact, CD40 is more prognostic, but CD8 is not prognostic. In fact, CD8 appears to be predictive. And that's shown here. We're still studying what else we can use as predictive, because this is what we'd want to use with the high stage patients, but it's not clear that any of them, even if they do poorly on immunotherapy, would not receive immunotherapy. So we're still trying to understand how this plays into clinical utility. And so with that, I'd like to move on and begin a discussion of digital spatial profiling. I think that we can, at the end of my talk, after I stop projecting my screen, you can put your questions and comments into the chat feature of Zoom, and then we can have discussion. So write down your questions about TILs now, because the next half of the talk is going to be about digital spatial profiling, which is really not about TILs. But I'm always excited about being able to identify cells in situ and maintaining the spatial information and not grinding it up, whether it's TILs or other biomarkers. And this, there are many multiplex technologies. In fact, at AACR, I just gave a review of all the different kinds of multiplex technologies, and that's for another time. But the one that I've really focused on in my own lab is digital spatial profiling, or the NanoString GeoMx. So the GeoMx method is shown here. This is the box that we now have in our lab. And what you do is you take an antibody and you conjugate it with a single-stranded DNA tag. And then this tag hybridizes to a barcode, and then you count the number of barcodes. So by counting the barcodes, you have a surrogate for counting the antibodies. And the way the process works is that you define regions of interest by a molecular interaction, and then within those regions of interest, you shine a UV laser, and that cleaves that barcode away from the antibody. And then you come by with a little sipper and sip them up in a microcapillary tube and put them in a 384 96 well plate, and then you use your counting machine. In our case, we used Encounter, the NanoString, but now we're just starting to do also sequencing, because you can also make a library of those tags and count them that way. And then you have essentially counted the number of antibodies in each of the spatially defined compartments, even though it's really a field of view technology or region of interest technology, not truly a single cell technology, unless you circle single cells. So some people are using this as a single cell technology because they circle a single cell. However, this runs into resolution issues. This technology has a maximum resolution about 20 microns in our hands anyway. And so that can be more than one cell unless you have widely separated cells. You can just do a whole field of view, which is sort of the geometric region of interest, or in our case, we use phenotypic is the way they call it. I like to call it molecular compartmentalization, where we define with fluorescence regions of interest in this case, and I'll show you how we do that. In this case, our regions of interest were CD68, CD45, S100, defining melanocytes, and then pretty much everything else. And when you do it this way, you have these serial molecular compartments, and then you have sort of an average across, in this case, a TMA spot, but you've maintained the spatial information without actually making an image. this is now detailed in this paper from Chris Merritt and the group at NanoString, if you want to go really into the details of this. But we use this application in breast cancer to try to find a new biomarker for resistance to trastuzumab. And this was a cohort that we had from our colleagues in Greece, the so-called HECOG 1005 cohort, which was our training set, which we had as a tissue microarray, 151 patients treated with trastuzumab. And then our validation set was the NeoALTTO cohort, which we couldn't actually do on DSP, but I'll show you some data from RNA from the NeoALTTO cohort to validate our findings of protein using the digital spatial profiler. And I love these slides. This is John Bathiotis, who's done this work now back to his fellowship in pulmonary oncology in Greece and working in Athens. But when he was in the lab, he worked with the digital spatial profiling, and each of these, this shows the power of this. So in his case, we did a 58-plex. Our newest studies were up to 78-plex. That is 78 different, or in this case, 58 different antibodies on 151 patients. So for each of these antibodies, so they're listed along the x-axis, we have the full distribution of all 151 patients, and then the level of expression on the signal to background ratio. And so probably anything below 0, and I'm not going to go into how we normalize all this stuff, but you can see a lot of the markers are sort of below 0. And even though, and that's the case, many of these markers that we looked at don't have a lot of expression. In fact, we talked about TILs in breast cancer, and there weren't many polys, and this is a marker for neutrophils or polys. And you can see there's not much that's above the threshold, the 0 mark. But there's some things that are really highly expressed and always expressed across the range, and there's some things that are expressed in half or more of the breast cancer cohort. And so using this data that we can then start to do discovery type tools to look for where there's an association between the biomarker and the expression pattern, looking at 151 patients and 58 biomarkers all at once. And so that's what we've done here. And the first, some interesting things that we found both in the CD45 compartment was SMA. Well, as pathologists, that makes no sense. We know that CD45 there's not SMA in leukocytes. So what's going on? And in fact, so then we combine these two compartments to make a stromal compartment. And there it makes more sense. If we have total stroma, because remember, the resolution of this thing is only 20 microns. So we can't really define a single lymphocyte, but mostly what we're getting when we're looking at CD45 is probably the stroma around the lymphocytes. And we combine them into stroma, we get a pretty compelling, statistically significant with a hazard ratio of 5.64 variable that does worse. So the first thing we have to do is say, okay, this DSP thing is cool, but it's a discovery tool. So how does it perform? How do we validate it? Well, before we validate it, let's look at just how each compartment performed in univariate and multivariate analysis, and then with Kaplan-Meier curves. And what we saw is the patients with high levels of SMA in the stroma do quite a bit worse on trastuzumab, and the ones that have low levels are more likely to not recur, even though this entire population got trastuzumab. And here's the hazard ratios in the forest plot of this case, based on the SMA and the stroma associated with progression-free survival. Now, to validate it, we wanted to do something that's a little more tried and true, and for that we used quantitative fluorescence. And in my lab, the way we use quantitative fluorescence is always using this aqua method. Actually, we sometimes use inform, but we use these two methods predominantly. The aqua method, developed in my lab close to 20 years ago now, is a way of not segmenting cells, but defining compartments by their molecular co-localization. So a DAPI-positive pixel is a nucleus as opposed to a round thing. And in this example, we're showing the intensity of the target pixels, which in this case was estrogen receptor, divided by the pixel area, so that you're normalizing by how much area there is. And so you don't have to actually segment and define cells, but you can still get an estimate of the amount of protein that's present, which we've shown in other papers are directly proportional. This aqua score is directly proportional to the number of femtomoles per microgram total protein. And so here we can look at it with quantitative fluorescence and look at the different molecular compartments or masks that we can define with aqua. And you can see that the CD45 mask or the tumor mask represent what we see here, but the mask dilates out. It's not just strictly where CD45, the white is, but it also flows out. And at higher power, you can see that in fact, the red, which is the SMA, is not in the CD45 cell, but it's in the stromal compartment, exactly where we'd expect it. So this technique, which is spatially informed, directed us to the right compartment, not specifically to the right cells, as we see most of the smooth muscle actin present in the stromal compartment, not in the cytokeratin compartment or tumor compartment, and not strictly in the CD45 compartment or the leukocyte compartment. But when we did it by aqua on the same cohort, so this is not really truly a validation, it's a validation by using an orthogonal technique. That is, we're now using QIF instead of DSP. And so now we only have two compartments, tumor and stroma, and only one antibody, alpha SMA. So a lot more limited, not as good a discovery technique, but much more quantitative in some ways. And so if we compare the two, they actually do pretty well. So this is alpha SMA in the stroma by DSP, and this is alpha SMA in the stroma by quantitative fluorescence. And they're highly correlated. And in fact, using the SMA low versus SMA high with quantitative fluorescence, we also see statistical significance in this same cohort. Of course, we haven't done a validation set. This is still the same cohort. So it's hard to find patient cohort tissues that are treated with trastuzumab. And in fact, I understand Karolinska has one. So we'll be coming and knocking on your door shortly to do this assay on your cohort, or perhaps you want to do it because it's so easy to do. We all do alpha SMA in our labs to identify different kinds of sarcomas or to look for myoepithelial cells. And this is just regular old alpha SMA, the same one that we use in our routine immunohistochemistry labs. But so what we did instead was look at alpha SMA mRNA, since we had mRNA-seq data, RNA-seq data from the NeoALTTO trial. And the NeoALTTO trial was trastuzumab versus lapatinib versus both in the neoadjuvant setting in breast cancer. And you can see in the trastuzumab treated, high alpha SMA RNA was associated with worse outcome. So thereby validating the technology with both an orthogonal technique and orthogonal method. You could argue, and I would agree with you, that in fact, perhaps this is not the very best way to validate since we need to have protein validation. But I look forward to trying to use alpha SMA, and this is where my lab is now. We're just writing grants and hiring personnel to look at alpha SMA in the neoadjuvant setting of patients treated with trastuzumab at Yale. And as you know, the whole ground is shifting with trastuzumab deruxtecan, and so there may be a much larger group of patients, and we don't know how alpha actin will perform in the setting of that drug, which is something also a future direction. So finally, to conclude, it's not advancing. There we go. In the HECOG cohort, alpha SMA in the stroma was associated with disease-free survival in HER2-positive breast cancers. The stroma alpha SMA was the only independent association with disease-free survival, and that RNA-seq data from the NeoALTTO study was used ultimately to validate our findings in the HECOG study. But perhaps the most important conclusion is that alpha SMA is easy to use. Pathologists have been using it for years in our clinical lab. And so I'm hopeful this could be a pathologist-driven method for evaluating patients potentially in the neoadjuvant setting who should have more than just trastuzumab. Although with trastuzumab deruxtecan and the changes that are occurring in the HER2 space, this assay may be obsolete before it's even tried. But we'll see. It may also have value in trastuzumab deruxtecan treated patients, since our hypothesis is that when you have a lot of SMA, you're increasing the density of the stroma and making it harder for big molecules to get to the tumor. And certainly trastuzumab as an antibody-based therapy is a big molecule compared to small molecule inhibitors. So with that, I'll stop. And before I completely stop, I want to acknowledge all the people that really did the work. This is my lab group at Yale in particular, and my former lab group here. And a lot of the work I showed today was all the DSP work was done by John Vathiotis, and I showed you some work by Pak Fei and a lot of work by Balazs Ach. Our outside collaborators are shown here, and my Yale collaborators here. And unfortunately, the last time we had a real party face-to-face was 2019. So here's a picture of the lab group and our website. And at this point, I'll stop share so that I can actually see the chat, and I'll take questions. Hold on just a second here as I go through the, let's see. So it looks like in my chat, there are no questions. So if anyone would like to speak up and ask any questions, I see we have 63 people attending, which is very nice. And so if there are no questions, I can, I guess, ask the moderators if they have any questions, or if maybe there are questions and I can't see them. This is not as fun as being in front of you in Stockholm.
No, so if you don't have any questions, you can stop.
Okay, well, thank you all, and thanks to Drs. Hartman and Ach for inviting me, and I hope that you found this enjoyable. Oh, wait, here comes a question. Could you please elaborate on the roles of TILs in the context of PD-L1? Well, thank you for that question, because I think that's a really important question. And it's data that I didn't show that I showed in my presentation yesterday at AACR. I had a presentation in an educational session yesterday that the idea would be that we should look at TILs in combination with other biomarkers. And in fact, we have very nice data in both melanoma and lung cancer that if we take the PD-L1 positive patients that have PD-L1 in lung cancer, anyway, in the cytokeratin defined molecular compartment, and then we split those by CD8, that the patients with high CD8 do much better than the patients with low CD8, even though they're all positive for PD-L1. And we see the same thing if we use pathologist scored PD-L1. So combining them might be really interesting in the future. TILs might be a good way to do that, but I think we might have to use molecular tools as we combine them, because we're looking in PD-L1 positive patients. We have a great experiment would be to try this algorithm on PD-L1 positive cohorts, but those tend to be high stage patients. And as I showed you with our TIL algorithms, those really are very, not very good on high stage patients. I think we do better with molecular parameters on high stage patients, and the TIL algorithms and the artificial intelligence might be preserved for situations where we're trying to stratify low stage patients. We'll wait a couple more seconds and see if anybody else has a question. But if not, I'll wish you all the best. And oh, there we go. We have another one. Besides the density of myofibroblasts, are there other mechanisms by which the effect of trastuzumab could be explained? Wow, that's a great question. And I think there probably are. And one that we're looking into and proposing to look into once I get more funding to do this is actually look at what fibroblasts really are. So the cells that that are expressing the alpha SMA are most likely fibroblasts. But fibroblasts, as probably you all know, are probably not one cell type, but are more likely 5 or 6 different cell types that all look the same. So we pathologists and people in general call them fibroblasts. So I would like to do some molecular dissection of the fibroblasts and see if it's actually something, if it's not just the physical barrier, but some cytokine or lymphokine or some molecular secreted factor is also associated with this resistance to trastuzumab. And so that's what we're thinking in terms of future directions with looking for resistance to trastuzumab. And especially since we're seeing trastuzumab drugs TCAN take off in the rest of the world. We don't have a trial of that yet here at Yale, but I hope to be able to look at that and see if it's actually more complicated than simply a physical prevention of antibodies approaching the tumor. Okay, I think that's probably enough. Thanks again to the folks that invited me, and I wish you all the best and enjoy your evening. Bye-bye.